effectiveness, not only in service delivery, but also shaping the health policy and ensuring equity. This webinar is part of a 6-part series. It's our 3rd webinar. It is supported by Vive Europe, and we will showcase peer-led innovations and monitoring frameworks grounded in lived experience. I will be guiding you through today's session, and I am very excited to introduce the powerful voices and organizations we'll be hearing from. So this session is recorded. There will be a translation, a consequent translation for Roman from BerLUN, and please keep yourself muted unless you are speaking. Of course, we encourage all the questions. Please use the chat box throughout the session, and then we will open the question and answer session. Okay, so to start, I would like to present you Thomas SEYLER. He is a scientific analyst at European Union's Drug Agency, and he is working as infectious diseases field epidemiologist in Europe, Africa, and Asia. So, Thomas, the floor is yours.
Thank you very much, Ligia. Can you hear me okay? Is the sound okay?
Yes, it's fine.
Great. Can you see the PowerPoint? Yes, but is it the right mode? Because this is sometimes the issue. It's okay? Okay, great. So I'm going to provide a brief summary of drug-related infectious disease in the EU. So I work for a European agency based in Lisbon, looking at drugs and impact, health impact, but also the supply side. And all the data I'm going to show you in this presentation is available online. So feel free to have a look at our website. I will give you the exact address of EUDA website at the end, but you can Google it. So I will start with a few words on the denominator. So as an epidemiologist, it's important to know first to measure the size of the population at risk we are talking about. So at EUDA, with our national focal points, we estimate that there are about 500,000 people who inject drugs in the EU. That's for 2023. The trend, if you look at data from drug treatment centers all across the EU, you see that people entering drug treatment for heroin, for example, are less and less reporting injecting as a primary mode. Nevertheless, it's still there. And for other substances like cocaine, it's not decreasing at all. And you can see on the right-hand side that the prevalence, as expressed as a proportion of the total population, is wide range, right? So you have very high prevalence of injecting drug use in countries like Estonia and Finland, and less so in countries like Spain or the Netherlands. Now, looking at HIV notification, again, in the EU, this graph shows the notification per million population, notification of HIV that are linked to injecting drug use, right? So you can see a peak around 2010, 2011. That's the huge outbreak or the big outbreak in Athens and in Romania, so Greece and Romania. You can see also during the COVID pandemic and the lockdowns, there's been a decrease, which is basically reflecting the lower testing rate among this time. But I think overall, the main message of this graph is that there's a declining trend, which is relatively good news. However, we are still below the UNAIDS target of reducing incidence, if you look at this as incidence, of like reduction of more than 75%. Which is the UNAIDS target, which we all committed to reach. So we are below that target. So despite, I would say, this relatively positive trend, we are still seeing in the EU HIV outbreaks linked to injecting drug use, which, I mean, importantly for us, are usually associated with stimulant injecting. So here an example, and this is available on our website, but for example, the latest outbreaks in Greece, in Thessaloniki, linked to injecting of heroin and cocaine. Luxembourg, Cologne, specifically cocaine injection. That goes back to 2014. In Dublin, synthetic catenones, another type of stimulant drugs, was linked with the outbreak. So overall declining trends, but we are still seeing relevant local outbreaks, mainly driven by stimulant. And what I want to say with this slide is that looking at the amount of cocaine available on the EU drugs market, reflected by the seizures, more than 400 tons were seized last year. It's a record. And also looking at some of the indicators we have at EUDA. On the right-hand side, I'm showing the results of a project we have where we collect used syringes in low-threshold services across European cities, and we test the content of those used syringes for all the drugs. And here it shows the results for cocaine. So you can see that in quite a few cities, the majority or large proportion of syringes contain cocaine. So people are, I would say, increasingly injecting cocaine, at least as reflected in this project. Cities like Madrid, Barcelona, Dublin, Cologne, even Riga and Thessaloniki have more than half of syringes, used syringes, testing positive for cocaine. And that's worrying because we believe it's an additional risk factor for HIV, but also viral hepatitis transmission among this key population. Now, looking at viral hepatitis, HIV is of course very relevant for our key population, but I would say hepatitis C and B, C certainly even more relevant. The burden of disease is very high. And to give you an idea, the latest estimate we did with ECDC colleagues is that a third of the 1.8 million patients with chronic hep C in the EU are linked to injecting drug use, whether past or current injecting drug use. So a huge challenge for the EU, for this key population. However, we are seeing positive signs. This is, I would say, relatively good news. It's not enough to be satisfied, but we're seeing downward trends in some cities, or some EU countries, some cities, notably. I will name a few. So Oslo, Madrid, Stockholm are three examples of cities that have conducted very good studies showing that over time, the prevalence of chronic hepatitis C among people who use drugs is declining significantly. Oslo, by the way, has reached the target, the elimination target, so to speak, of a reduction of 80% of that prevalence among that key population. These are the positive news. I mean, for many other countries and cities, we are still observing very high and not declining levels of hepatitis C infections, which means there's still a lot of work to be done. What I wanted to say also with this slide is that in those countries where we see a progress, they all implemented what we call an integrated approach to prevention and treatment, right? So the involvement at of low threshold services, linking patients to prevention and treatment when necessary, right? So you need a decentralized approach with resources for harm reduction services that are in contact with drug users. That's essential, and that's probably why it's working in those cities. The overall picture, I wanted to show you this slide to show you that the overall picture is still, there's still a lot of progress to be done. This shows how EU countries are ranking in terms of achieving the WHO target of clean syringes being distributed every year to the population, and also access to OAT, so drug treatment for opioid dependency. And what you can see on this graph is that most countries, majority of countries, are not reaching those WHO targets for harm reduction coverage. Only 7 countries are reaching it, according to our latest data, which is clearly not enough. And that's really also important for prevention of HIV, viral hepatitis, and many other illnesses because the entry point to primary care and treatment are, in most of the cases, those harm reduction services providing syringes and drug treatment. So so despite the progress, a long road still to be done and to be completed. I also wanted to stress the fact that we are seeing infectious disease transmission and a higher burden of infectious disease of other pathogens among our key population. I've listed examples of 3 here, but there are others. Hepatitis A, there's an ongoing multi-country outbreak affecting different subgroups, but among the affected population, you have people who use drugs. Diphtheria, so we're talking relatively few cases. However, there's a resurgence of diphtheria cases. We're talking about people that are not vaccinated, and some of the risk factors, or at least is a high exposure to drug use among the latest documented cases. And monkeypox, with the link, at least at the early stage of the monkeypox outbreak, or the mpox outbreak, sorry, in Europe, a link to chemsex, for example. What I wanted to stress also today, if I have a few more minutes, is in our work at EUDA, the role of civil society is key at many levels. So in terms of monitoring, for example, and here I have 2 examples of protocol that we use for monitoring. The one on the left is the infectious disease models of studies that we are putting forward. So there are examples of high-level or state-of-the-art studies, seroprevalence studies conducted at the local level. They almost all involved civil society organization, harm reduction services, implementing or doing the studies in collaboration with the public health institutes or universities. So they are key to the monitoring. Same for the ESCAPE network, which I mentioned, which is the project where we collect syringes in a sentinel network of cities. Harm reduction services and usually civil society organizations are key to these type of projects at the European level. And obviously, civil society as a key actor for interventions. On the left-hand side here, you have our latest joint guidance. We call it interagency guidance that we produced together with ECDC. That's the agency in Stockholm. Again, few examples. If you read that guidance, which is available online, you will see that we emphasize the central role of low threshold harm reduction services for the whole continuum of care, so to speak, of key populations. And we also look and observe and document the effectiveness of community-based interventions, such as testing and also peer-related interventions. On the right-hand side, we have the latest publications we did with ECDC focusing on prison settings, where again, you will see we are documenting 5 examples, concrete examples of what's going on in 5 prisons in the EU with really interesting models of care, where civil society in and out of prison, because the concept of continuity of care is crucial, where civil society organizations are we're at the core of the success of those interventions. So as a conclusion, people who inject drugs and people who use drugs accumulate a high burden of infectious disease. That's important for us. These infections are preventable and some are treatable, and with cost-effective and sometimes cost-saving interventions, distributing sterile material, injecting material is a cost-saving intervention. And of course, harm reduction services are essential actors in the monitoring, but also, of course, the implementation of the responses. And I wanted to finish by sharing with you an article that is part of our regulation as an agency. So that states very clearly, and this has been adopted by the European Parliament and the Council, so it has been going through the European democratic process. So an article that says that the agency shall maintain cooperation with relevant civil society organizations active in the fields covered by the regulation. So we are really aware and thankful for the work of civil society organizations. I will be happy to take any questions and discussions or to continue the discussion after the other presentation. Thank you very much for your attention.
Thank you, Thomas, for this important presentation on the situation in Europe. We will now go on with Anton Basenko. Anton is based in Brussels now, but formerly from Kiev, Ukraine. He's a master's degree in international economy, a globally known activist of the community of people who use drugs and OST patients, people living with HIV and lived experience with HCV. Since 2010, he started his work in HIV and TB service, harm reduction and advocacy field in local and national NGOs in Ukraine. He's worked since 2013 with Alliance for Public Health, coordinating international and national projects on HIV, TB, and viral hepatitis, advising communities, rights, and gender issues. He's author of different articles, guidelines, and publications for communities and professionals. He's also a founder of INPUD UA, board member of INPUD, member of the Communities Delegation of the Global Fund Boards, and CCM of Ukraine. Okay, is also program manager on quality of life in EATG team. I will stop for now. Anton, please go ahead.
Thank you, Ligia. Just to be clear, formerly program manager in the European AIDS Treatment Group, yeah, and formerly board member. So for today, I'm speaking as a executive director of the International Network of People Who Use Drugs. This is the only peer-led network, global network, represents the interests and defending the rights of the community of people who use drugs globally. I think to our members and our allies and friends, the Euro INPUD, for the invitation to attend this event. I know that this event is just a part of a series of different events, and I think that it is really right time to have this discussion. And well, it is an honor for me to welcome you all to this important session. We are ready. European people who use drugs communities respond to HIV, and for me personally, it's not just a title. It is a statement of a fact, and I would say it's even a call to action. Let's try to begin with the reality that brought us all here. You just saw the data and really a clear picture from the colleague from EUDA. And for the first time in over a decade, the European Union is seeing an increase in new HIV infections, and especially my region where I'm from, Eastern Europe and Central Asia, which is considered globally as still now not the only region with increasing epidemics, but over the last decade or even the last years, it was the only. Now there are data that it's again Latin American, Caribbean region rise, and some other countries in some other regions, like for instance, the most recent case, it's Fiji with 500 times increase, and data says that it happens within the community of young gay men who use drugs. So of course, we are looking for an urgent approach to support the community there, but let's land back to our region. So as I said, it's the first time in over a decade when you've seen this increase in new HIV infections, and that should stop all of us in our tracks, because despite major advances in treatment, despite all these political declarations about ending AIDS by 2030, in fact, we are moving in the wrong direction. For people who use drugs, this is not a surprise. because we have been warning for years that criminalization, underfunding, and neglect are leaving our communities behind. And I speak to you today not only as the executive director of INPUD, a little bit about myself, someone who has lived through it with what punitive drug policies mean in practice. Well, I started using drugs at 14, stimulants. It was mid-90s. I was a teenager. So it's the first years of post-Soviet independence for Ukraine. New substances coming, of course, no harm reduction programs, no any proper information about some risks, and this brilliant experimenting age. So I started to inject already in 16 with opioids, with heroin. And what's happened, I waited 9 years, I think, before I got my first clean syringe in the harm reduction program, before this program really came to my country and reached me personally. 9 years, and of course, sometimes you cannot even stay alive till this over these 9 years. So it was not a big surprise for me. I've been diagnosed in 2003 with both HIV and hepatitis C. I waited 712 days for my ARV because at that moment there was no treatment for all people who need it. So you can be prioritized only when your CD4 cells dropped less than 200, and it's already an AIDS stage. So in fact, you have to wait until you start dying, let's say, when you really can have this golden ticket and access to the treatment. For hepatitis C, I waited even longer. That's a different story because you know that Hep C is a polite killer, or how they call this in Russian, it's ласковый убийца, like, yeah. So of course it's asymptomatic during some years, but even when I realized that I need the treatment was not there, or the treatment which appeared, it was still old-fashioned treatment with interferons. It was not okay for me. Yeah, so I have survived 6 overdoses, well, at least 3 denials of medical care. I mean, officially or not officially, 2 job losses due to my status, and I was very close to prison 4 times. Well, I spent some time in detention center, but thanks to my dad, who was working for Ministry of Interior, so he saved me all the time. I share this not for sympathy, but because my story is not unique, and it is the story of millions of people across Europe and beyond. And it is shaped not just by health risk, but by policy choices. And choices to criminalize instead of care, choices to fund prisons instead of prevention, choices to ignore peer-led networks, even when we consistently deliver results. So where we stand today, across Europe, harm reduction coverage remains patchy and fragile. You know that opioid agonist therapy still unavailable or severely limited in several countries. Unfortunately, bad things happening in the Eastern Europe, in Georgia, due to pro-Russian government decisions. All private OET clinics have been closed, cutting off thousands of patients from trusted care. It's not like they all been left on the streets. They were proposed to join the program in the public healthcare facilities, but unfortunately in Georgia, public healthcare facilities, it's lots of limitations, almost no take-home dosages, control, all these punitive measures instead of the harm reduction philosophy and values. Needle and syringe programs also globally, it's still lack in Europe, well, in Western Europe, in Western European world. It's better in Eastern Europe. It's not so good. Well, Ukraine has the largest program. Few countries, and Ukraine recently started the NSP program in prison settings. But what's happening with geopolitical Russian influence, that some countries who were considered as the pioneers of needle and syringe programs in prisons such as Kyrgyzstan. They closed these programs from summer this year. So once a global leader, prison and SP were shut down under this pressure. Stimulant users left as a big gap because across the region, pharmacotherapy is not existent. In Ukraine, we have a pilot, but it was launched with huge opposition from guess who? The people who should be your first ally, public health center of the Ministry of Health, right? But in fact, they were the first who were opposing to this idea and implementation, though we are trying to not only replicate or implement the experiences from countries like Canada, UK, Australia, but also from our closest neighbor, Czech Republic, which has a program not only with methylphenidate as pilot in Ukraine, but also with dexamphetamine and lexamphetamine recently, though they still using the gray zone approaches, to use this off-label medications because yeah. So and the stimulant users, of course, it's much larger army, I would say, than opioid users, and it needs attention. So at the same time, we face a global funding crisis. INPUD's human costs of policy shift report, Lydia, you can copy the link to chat, or I can do that after my presentation. Unfortunately, I was not able to do the slides, but I will just share few things. Thanks for sharing the IDoIT, the implementation tool for programs for people who inject or use drugs. It's really almost like a Bible for the programs for our community. So everyone, every organization, every person, every activist, everyone who wants to start working with this community should really, first of all, use the IDoIT tool. But let's get back to the funding crisis. So our policy, human cost of policy shift report, sorry, just a second. Sorry. Sorry, my kid was trying to draw my attention. So our report, which is based on the survey happened in March and April, shows how donor withdrawals have hit harm, not only harm reduction services, but community-led organizations of people who use drugs and community itself. In some countries, organizations lost from 26 to 100% of their budgets overnight. Clinics closed, outreach stopped, outreach, which for a second is a basic element of the harm reduction programs. If you remove outreach, peer work or outreach approach, in fact, you're blocking the entire harm reduction model and any further services. So like peer educators were laid off. So the result is higher HIV and hepatitis C transmission and more overdose deaths, all of which are preventable, in fact. But there is hope and opportunity. I think we are not powerless. In fact, we are at a turning point. In 2024, you know that the UN Commission on Narcotic Drugs for the first time explicitly recognized harm reduction and in its normative framework, breaking decades of silence at the global level. And recently this year, on the 68th meeting of CND, Commission on Narcotic Drugs, Colombia, with the support of other member states, challenged the old consensus, also first ever in the history of UN Commission on Narcotic Drugs, faced resistance, but won historic decision to conduct the first ever independent external review of the international drug control system. What does it mean? This really opens the door to rethinking the punitive drug control model, or so-called model of war on drugs, which we are all suffering from for decades, and that has harmed so many of us for really so long, and not only us, but our beloved ones, our friends and colleagues. And from 2026, the CND will also include new members from Europe and Central Asia, Lithuania, Slovenia, Ukraine, Kazakhstan, and Kyrgyzstan. These all giving our region a stronger voice than even before. And at the same time, Russia has been So the Russian the term of Russia has been ended. So and Belarus as well, as far as I remember. Yeah. So we have a really a window of opportunity, and this is really a moment for Europe to lead, to align EU policies with human rights, with evidence, and with realities on the ground. So my last part of the speech: why actually peer-led responses matter. Community-led organizations, many of them represented in this webinar, are not just filling gaps left by governments. We are really delivering cost-effective, scalable, and life-saving programs, and that is the potential solution in the situation of the global funding cuts. Peer outreach, which reaches people no one else can reach, those most marginalized, most criminalized, most hidden from public systems. That's what we do, what we know how to do, and what we are able and motivated to keep doing, with money or without money. This is our life motivation, right? But of course, with resources, we can do that properly, scaled up, and achieve really good results. Integrated harm reduction models, which provide not only sterile syringes, but opioid agonist therapy, long-acting forms of OAT, take-home dosaging, HIV testing, linkage to antiretroviral therapy, hepatitis treatment, overdose prevention, and psychosocial support. It's good that now this agenda extended to mental health services as well. And of course, we need the community monitoring tools. It really matters. One of the tools you can find on our website. You can use it, but also there is a tool from EUDA and see correlation in Arran, as far as I understand, which give, as far as I remember, which give policymakers real-time data on what is happening long before official surveillance systems catch up. So we are not beneficiaries. We are really strategic partners in achieving Europe's HIV goals, but we cannot do this on a goodwill alone. We really need political will and funding and protection. So our message today, as we move into the presentation from my colleagues and friends from BerLUN, ProLAR, GATT, and CHRN, I ask you to view them not just as a case studies, but as really a proof points that community leadership works and must be scaled up. Ending AIDS by 2030 is still possible, but only if we stop criminalizing people who use drugs, invest in peer-led services, and integrate harm reduction into every national HIV and health strategy, including EU drug strategy, which is the finalization or discussion ongoing right now. And it's I think good opportunity to say that yesterday I spoke at the first meeting of the EU interest group on drug policies, under European Parliament. It's been launched by the MEPs from Ireland, from Czech Republic, and from Lithuania. But the drug policy agenda is supported by a number of countries, so I think we will have more and more representation. So stay connected with us, and we keep advocating. So let me close by saying this: we are ready. We ready to partner with governments, EU institutions, and donors. We are ready to scale what works and innovate where gaps exist. We are ready to help ourselves accountable through evaluation, monitoring, and evidence to prove our impact. The community of people who use drugs, I always say, is not a problem to be solved. We are part of the solution, and we stand ready to be committed partner to policymakers, funders, and public health systems across Europe to get this job done. Thank you for your attention.
Thank you, Anton. Great presentation, very timely, and very bringing us very fresh news, let's say. You detailed some of the challenges, and you brought us a good perspective on and a motivational perspective for the community, and it is very important in these difficult times. Thank you so much. So we will now will flip a bit the plan that we had because we are inviting now Roman Ledkov to follow Anton. Roman has been working in harm reduction and prison health for almost 20 years. He is a staff member of BerLUN AIDS Health and a board member of BerLUN, which is a peer-led migrant organization. He's living with HIV himself, and he combines professional expertise and community engagement to support people who use drugs and people in detention. Roman will speak in pieces so that Anton can follow with the translation in English. Thank you, Roman. Please go ahead.
Алло. Антон, спроси, пожалуйста, видно слайды
Да,
мои?
видно слайд. Oh, sorry. Sorry, can you see the slides?
Я попробую с приготовленным переводом на слайды, Антон, хорошо? А потом, если где надо, я буду тебя просить.
Okay, Roman will try to start with the already prepared translation, which you can see on the slides. But if it doesn't go well, then he asks my help. Yeah, go ahead. Пожалуйста.
I have been working in BerLUN und Berliner AIDS-Hilfe, AIDS-Help-Organisation und providing counseling and support for people living with HIV, hepatitis, and drug dependence. Since last year, I have also been serving as the chair of the board, es war gesagt. Und out of approximately 50 regular clients and around 300 people reached by our services each year. Ja, und annually the 5-7 ist sterben. Ja.
Может, лучше, если ты... Да, потому что ты на немецкий переходишь, я боюсь, люди...
Да.
Да. Yeah.
Mhm.
Ну, если у тебя написан текст на английском, ты можешь его читать, то читай. Но я чувствую, ты переходишь на немецкий, поэтому смотри, как чувствуешь.
Ja.
Хорошо. Окей. Ну, давай, попробуй еще на английском. Yeah, I'm just proposing Roman maybe to switch to English because I feel because last year's because where he's based his language is German as far as I understand, and he's naturally moving slightly to German and maybe it's confusing.
Я постараюсь коротко. As a group of activists, we are still very weak, lacking structural und organizational support, und we experience discrimination from state institutions that do not want to acknowledge the presence of migrants in Germany. Nevertheless, we do have a number of partners with whom we are successfully developing. Slide. Meine Activity von uns we provide peer counseling, individual support, and group counseling in the format of self-help groups. Over the past 3 years, we have been working mainly with refugees from Ukraine, but many of our clients are also people who use drugs from the Baltic states, the Caucasus, Moldova, Belarus, Russia, and Central Asia. Und Антон, теперь с тобой.
Мгм.
Собственно, результатом на данный момент является установление такой, ну, стабильной группы активистов, такого актива, да, и у нас большая часть наших, ну не то что больше, а большая часть энергии и сил уходит на адвокацию.
So as of today, the main result is setting the really a sustainable group of activists, but their meaningful part of the time and efforts goes for advocacy.
Вот. И, собственно, мы очень благодарны за то, что вы нас приглашаете, и мы чувствуем себя частью европейского сообщества людей, употребляющих наркотики, и надеемся на лучшее, хотя времена очень тяжелые для всех. Спасибо.
Yeah, and that is why we are very thankful for having this invitation that you are inviting us to your events, and we keep feeling ourselves as a part of the European community of people who use drugs, because honestly, the times are very difficult and challenging now for our community. Thank you for your attention.
Thank you, Anton.
Спасибо, Арман.
Thank you, Roman, and thank you, Anton. It was very interesting to that you brought your work in where there is still the need to expand and to work with this key population that needs attention. Thank you so much. So we will now go on. We will move to Prolar and Marianne Pierron. She will tell us about their work in Norway, more particularly in Bergen, Norway. So we welcome now Marianne Pierron. Go ahead, Marianne.
Hello, everybody. Thank you very much, Lydia, and thank you for being with you here. I will try to share pictures from our house. I'm not that good in English, so I need my papers, okay? Let's see here.
I would love to help you with translation from Norway, but I don't speak Norwegian.
You don't?
At least with French. If you can speak French, we can try.
Okay, let's see if I can share this with you. No, it doesn't want to. Okay. Anyhow, I'll just start. So, okay, let's start sharing. This is maybe some pictures. I am allowed to show you all the pictures which is going through here. Anyway, I represent BerLUN, which is the national youth organization for people in Oud, Norway. I'm also the daily manager of the house led houses, Huset Bergen, the house of Bergen, and the night house, two peer-led initiatives in Bergen. Additionally, we also have Huset Oslo and Huset Stavanger, two peer-led houses in other cities than Bergen. At BerLUN, Huset Bergen and other houses, our work happens on all levels. We are participating in research. We are influencing policies and services at the system level and work directly on the individual levels, supporting people in their daily lives. Huset Bergen is owned by BerLUN. It's also owned by Alarm, user and next to organization, and FOL, which you all know from INPUD, Arild Knudsen and John and so on. At the heart of our work, our idea is citizenship, human rights, and peer-led services, Almost all the people we meet, our guests, have lived much of their lives in the shadows of the society. They have been marginalized, stigmatized, and excluded. Our mission is to help them reclaim their place as a full citizens with dignity, rights, and voices in the decision that affects their lives. Our mission, our principles is simple. The voices of people who use drugs must be part of shaping the services and policies that affect their lives. Bergen, at Huset Bergen, we run daytime drop-in center 5 days a week, 10 o'clock in the morning to 21 in the evening. The night house is an overnighting shelter for homeless people who use drugs, open every night through the year from 22 in the evening to the 9 in the morning. They all get food, they all get clothes and bath and warmth and help. We are not a treatment facilities, we are community spaces. We offer food, warmth, a place to rest, but most importantly, peer-to-peer meetings, dignity, belonging, and recognitions as full participants in the society. We are peer-led. Most of our 52 staff people, around 40 of them have lived experience themselves or are currently living with it. The same applies to our volunteers. The rest of the staff are close to lived experience. This changes everything because it builds trust and shows that people with lived experience can lead, contribute, and be heard. It's a little bit like this with sharing here. Just give me seconds. Hepatitis C, from the bus to integrate care. Back in 2017, when Prola started this work, more than half of the patients in OAT treatment in Norway had chronic hepatitis C. We begin with the hepatitis C bus, bringing testing directly to people. And if someone tested positive, even if they were reinfected, they were given a prescriptions and treatment on the spot. This low threshold immediate treatment was critical. It not only addresses the health, but also reinforced that people matter and have the right to care, regardless of past stigma or marginalization. Today, hepatitis C care is integrated directly into OAT service thanks to ProLanet's hepatitis C bus. We are now preparing a new study with PSC self-test kit, a home test kit for hepatitis C, which is further lowering the barriers. In the house, all of our houses in the 3 cities we do have, we also have built up something called the Bridge Builders, which is supposed to reach out and work out in the community. They're working in the outreach walk out to people, have peer-to-peer conversation, and meet people as equals. They help guests reconnect with the system, access housing, enter out treatment, receive university education, or obtain medical care such as pain management. Whatever our guests or participants needs help with, we are there with our bridge builders. And this is the key, not top down, but equal dialogue. Asymmetric and reciprocal. It's not asymmetrical, it's equal. It builds trust, uncover needs, and identifies where the systems fail, which we bring back to the table in the system level work. We also remind people that they are citizens with rights, not just service users. About HIV, in Norway, we are in a position when it's available and the outcomes is good. But across Europe, nearly half of all our HIV cases are among migrants. In Norway, part of the recent increases was linked to refugees from Ukraine. This highlights the needs for low threshold, adapt stigma-free services, harm reduction work from peer to peer, but also at all levels of the system, so that everyone can access care as part of society, not on the margins. So why the user voice matters, it's obvious, but I want to stress it anyway. It is not enough to have research about us. It must be researchers with us. This is why ProLAN is participators in studies on different projects, for example, on heroin assistant treatment, amphetamine substitutions, benzodiazepine in substitution treatment, lung health and dental care, among others pilots, which also the Huset Bergen is connected into through the other organizations as well. In all of these, the user voice is present in equal terms with researchers at the national level. Because if you want real answers and real impact, you need people with lived experience at the table, at full participants and co-creators. So in the end, I would like to sum up a little, but I want to show you a picture more, because I got a lot of beautiful, beautiful pictures from all these beautiful guests we got. They are from back in time, and it's from now, and this is from our first year, preparing our first year, celebrating. We have been running around now for 3 years. The Night House has been running for 1.5 years. The Bridge Builders is growing up from, they started with 2 in February, and now we are 6. And we also have this conference every year.
In love and war.
Together with...
Doors hit about 2 hours ago. It took mostly...
Okay, yeah. Anyway, to sum up, at ProLAN, Huset Bergen, the Night House and the other houses, Huset Oslo and Huset Stavanger, we combine research, system-level advocacy, and everyday peer support. We help people reclaim their places as citizens after years in the shadow. It's all about stability, dignity, trust, and the right to be heard. By bringing the user voice into every level, from research to politics to daily life, we achieve better health outcomes for hepatitis, no matter what, ABC, HIV, and beyond, while restoring people's places to the society as full participants. So we are quite proud of what we have got here, because we work in all the level. We are working together with business life. We are working together with researchers. We are working together politicals. We are in groups in everywhere. Yesterday, I was in a group in Oslo who is working to how we can prepare people coming from treatment and out and back to life. Not everybody wants to climb the mountains in Norway. Not everybody wants to play football, but what they do want is a home, not just a place to live, but a home. And then also need something worthing to do every morning. And I guess it's the same all over the world, that there is someone who's directing you where they think you should go, not what you really want to go, which means that if you are a really good chef, but you are like 40 kilo and got no teeth, nobody will hire you. So that shouldn't be the problem if you your weight or your look or your teeth if you are a really good chef. So that is what we're working for, to make everybody included on their own premises. So thank you, Ligia.
Thank you, Marianne, for bringing us this your work, the images about your work, and to show us how effective community-led work and initiatives are. Thank you so much for this. We will now follow to Valentina Mancuso. Valentina is active in Isola di Arran. This is the first association of people who use drugs in Italy, and is a member of the national Italian network INPUD. With experience in harm reduction, both inside and outside prisons, she combines her educational work with training on gender issues, as well as peer-to-peer training in harm reduction. She is also a member of the INPUD board and part of the Sisterhood network. Valentina, please go ahead.
Yes, can you share my slide? Because I can't share, I don't know why. Sorry for this.
Yes, we can share your slides. I'll just need to
Sorry.
I'll need to find them here and open them. I'm sorry, I wasn't ready for that. Here it is. Sorry, this will take a bit. I'm sorry, I'm not. Now I am, okay. So, no, sorry, I cannot, I'm don't.
Valentina, just send the slides to me and I'll try to.
Okay.
Please.
Sorry. I don't know why now. I can't
open them with the right, in the right way, because it is opening as a PDF.
Yeah, wait.
Okay, I can do it this way. Let me try.
Why?
Here it is.
Okay. Yes, sorry. Okay. So, okay, I can start. Good morning, everyone. Today I will talk about HIV and prisons, focusing on harm reduction in Italy, in specific in Turin. I think this topic is important because in Italy in particular, because prisons are often forgotten in the discussion about health and human rights. Yet they are places where stigma, vulnerability, and lack of care are very, very strong. Today, I would like to speak about Prometeo project and how Isola di Arran Association born, because it's really connected to the HIV situation in the past in Italy. The first big experience in Italy was the Prometeo project inside the Lorusso Cotugno prisons in Turin. It started in 1996, and Prometeo was based on peer support. So people in prison helping each other, sharing a responsibility and creating solidarity. This was not just healthcare. It was about building trust, dignity, and human connection to defend health and right hidden behind bars. Okay, you can go to the next slide. In the 1990, stigma against people with HIV was very, very extreme, even among prisoners. Many people, also people use drugs, were dying in silence. And Prometeo created a special section, more open, with sharing meals and a stronger sense of community. A key part of Prometeo was the role of peer. So inmates with direct experience of HIV and drug use. They were essential because they could mediate between inmates and doctor, improving trust and access to care, give daily emotional support with listening and presence, and reduce stigma and isolation, creating a safe space where people felt respected. This peer-to-peer model transformed care into something collective, not individual. It gives people in prison the power to become active agent of change. Okay, next slide, please. From Prometeo, we arrived to Isola di Arran, come l'Isola di Arran Association, the first association of people use drugs, founded in 1996. Since then, we continue to work with harm reduction outside and inside Turin prison. Our activity, our project now inside the prison include harm reduction on drugs, alcohol, and other addiction, prevention of HIV and ACV, distribution of harm reduction kit when people are released, like syringes, like naloxone, like a condom. We give legal information, and we organize training of new peer. Now we are the only association in Turin prison using a real harm reduction approach. Another focus, important focus for us, is gender. We work specifically with women and transgender people in substitution therapy. Yeah, you can go in the other. In substitution therapy, we address issues like gender-based violence, emotional dependency, and empowerment. The aim is to create awareness and give people tools to build autonomy and self-determination, even in the very hard prison environment. But look at the reality today, because it's very critical. In Italy, more than 1/3 of inmates in Italy are there for drug-related offenses because of Law 309 of 1990. Prisons are overcrowded. In Turin, the main prison has a space for about 700 people. But often there are more than 1,000. At the national level, at the end of 2024, there were 62,000 people in prison, but the official capacity was only about 45 people. This means an overcrowding rate of more than 132%. Overcrowding makes healthcare very difficult. HIV tests and ACV tests and treatment are not always accessible, and prevention programs are less effective. So the combination drug laws, overcrowding, and poor prison condition is a major public health problem. For this reason, but not only for this, civil society decided to organize a counter conference. Why? Because the official National Conference on Addiction often ignores harm reduction, the civil society of harm reduction, and does not give space to peer support or to the voice of people use drug or people with HIV. The counter conference will take place on November, the 7 and 8 November in Rome. It will be a moment for drug users, for activists, for association, professional expert, and other people interesting to come together to speak out and to push for more inclusive policies. It is not only about health service, it is about rights, about dignity and social justice. So I warmly invite all of you to join us in Rome. Together we can send a strong message that harm reduction work and peer support can change lives and nobody should be forgotten. I conclude with the history of Prometeo and the work of the L'isola di Arran show us something very important. Even in prison, people can become agent of change. If we put people at if we put people at the center and not their crime and on their drug use, we can build a good society also for us. Thank you. And sorry for the slide.
Thank you so much, Valentina. It is very impressive, the resistance and the sustainability of Isola di Arran. I think for many reasons, including these ones, Isola di Arran is really an example for the community-led initiatives. Thank you so much. So I would now ask Vincentius Avian, are you ready for talking with us, Vince? I know that you had some difficulties arriving, let's say, but are you ready now or?
Hi, Lydia. Yes, I'm ready. Thank you so much.
Okay, so Vincentius Azvian is a youth researcher from Indonesia working on HIV and harm reduction issues. In Indonesia, he is engaged with national drug policy reform to develop better regulations regarding drug policy. Vian, I will ask you to be as brief as possible because we were very generous before with our speakers and we would like to have a little bit of time for question and answers. I'm sorry for this request. I hope you can forgive me. Go ahead, please.
Thank you, Lydia. Hi, everyone. Thank you so much for inviting me. So actually, I'm facing difficulties when it comes to the time zone because I'm from Indonesia, actually currently in Jakarta. Hi, everyone. My name is Vincentius Azvian. You may please just call me Azvian or Vian. I'm here representing YouthRISE, organization of young people who use drugs in all over the world, and also in Timur Indonesia, organizations of young key population and young people living with HIV in Indonesia. I'm a young drug user from Indonesia and also young key populations. I will tell you a story. I think I'm not going to present a presentation. I will tell you the story and information regarding the HIV and harm reductions in Indonesia. In Indonesia as well is a country where the HIV transmission and HIV epidemic is really serious issue because it's currently it's in the amount of 500,000 cases until now in Indonesia, and yearly new cases, young people are among the highest group when it comes to the new HIV cases. For example, from 2022 since 2022 until now, it's always more than 50% when it comes to the new HIV transmissions in Indonesia. And also the access to the HIV services, to the harm reduction services is really a serious aspect that I'm currently working on with my organizations. In Indonesia, young people access to the HIV test, HIV services is available. But when it comes to under 18 years old, there are some difficulties when it comes to consent, especially to the harm reduction services and HIV test and HIV treatment services. But currently, they are allowed to access HIV services, all those services, without parental consent, as long as with the community healthcare worker or outreach worker. In Indonesia as well, if you work as an outreach worker to educate people about condoms, about the HIV preventions to young people under 18 years old, about the needle syringe program, about the needle, the clean needle to the people under 18 years old, you will get to jail because it's criminalized to do that in Indonesia, and we're still working on it when it comes to the criminalization to those educations kind of thing. And also stigma and discriminations remain really high, especially at the root is when it comes to the educations. Currently, there are no specific like implementation of HIV services, HIV education, about harm reduction education to the young people in the school settings because of the policies and also the inadequate educations when it comes to the implementation to the high school, middle school, and also elementary school in Indonesia. Also in Indonesia, I think it's very unique because the harm reductions. No, I will talk about the drug use first. I think in the HIV case, drug user is remain low now. Actually, like 10 years ago in 2000 and no 20 years ago, 2000 and 2004, 2005, it's really remain high when it comes to the HIV cascade among those people who use drugs, especially people who inject drugs. But as the time goes on, the cascade among those people who use drugs, especially who inject drugs, is remain lower and lower, and until now it becomes the prevalence is, I think, under 5% when it comes to those group in among those HIV cascade in Indonesia. And also when it comes to harm reductions, I think it's pretty sad because Indonesia is one of those countries who haven't implement or who have not any not harm reductions like decriminalizations policies in Indonesia. In Indonesia, the policies when it comes to drug, when it comes to those issues is, I would say, it's like a full punitive approach. And also we have a mandatory rehabilitation in Indonesia. So if you get caught using or distributing any kind of drugs, we have like some kind of 4 or 5 level of drugs here. You will get first of all, you will get into jail, and the second of all, there's a mandatory of rehabilitation policies in Indonesia, which is actually there is some kind of reformative drug policy reform in Indonesia, which is my organization also involved in this process with several organizations as well. We are demanding for the government to lower the ambang batas is the percentage of the the ownership of the drugs, of the substance, for people who to be able to get to release from jail, things like that. We are working on it, and actually there is some kind of a good news when it comes to the next year new penal code. We are working on it when it comes to those advocacy, and will be implemented next year 2026. I think it's going to be a long time when I talk about those advocacy, but yeah, Indonesia is facing a serious cases when it comes to HIV HIV transmissions among young people, and the service provider itself, it remain, I think, improving, but still facing several obstacles as well. But when it comes to harm reductions, I would like to like pulling it outside from the HIV, because the focus is really different. It's focused on like the drugs policies, the decriminalizations. If I always use HIV services to the harm reductions area, it will remain like nowhere, because the cases I said to you, it's remain lower now when it comes to this kind of relation between HIV and harm reduction or people who use drugs in Indonesia. That's all I think I want to share. Thank you so much for the space, for the time. Would love to hear from you more. Thank you.
Thank you so much, Vian. I think you made clear how things that maybe wouldn't be connected are really connected. And of course, criminalization of drug use is a cause a big dose of harm, of course. Thank you. We will now go for our last speaker, Arianna. I will make the same request as I did to Vian, and I apologize for that. Arianna Rogialli is a policy officer at Correlation, the European Harm Reduction Network, brings a diverse background encompassing various aspects of health and social justice to their role. With a particular emphasis on harm reduction, their background and interests also include sexual and reproductive health and rights and trans-inclusive healthcare. She's a medical anthropologist. Arianna is committed to contributing positively to the intersection of health, justice, and inclusivity within the realm of harm reduction. Thank you so much. Harry, please go ahead.
Hi, everyone. And first of all, I want to thank INPUD for inviting me today. And thank you, Ligia, for the introduction. It was also super insightful to hear from all of you and from a more local and regional perspective. I think it was really interesting to hear. So thanks to all the other presenters. So as Ligia was saying, I work for Correlation, European Harm Reduction Network. And I'm going to wrap up today and just reiterate a bit things that have already been said today, but still that are very important about why peer involvement is so fundamental for advancing the HIV response in Europe and in the world in general. And I will draw mostly from our work that a correlation we do within the monitoring. And the monitoring is a yearly process where we gather information on the state of harm reduction in Europe. And we do this thanks to our network. We're a membership-based network, and we have organizations that are focal points across all cities in Europe that provide us with information on the state of harm reduction in their location. And this monitoring is usually published in the chapters. And recently we've also started to do city reports specifically, but also for the last 3 years, we have coordinated another project that is called Boost. Boost is a project that specifically aims to support and to strengthen community-based and community-led organizations working in the field of communicable diseases. So today I will draw a little bit from the knowledge that comes from these projects. And later I will also share some links in the chat so that also you can learn more about this, but now it will be short. So what we see in our work is that people who use drugs constantly face enormous barriers when accessing care. And especially, for example, communicable diseases care. So, for example, stigma within healthcare systems, but also criminalizations or punitive laws, as some of you have mentioned before. Also underfunding that can lead to services being too few or missing. So imagine also that these barriers multiply when people are also marginalized for other reasons that are beyond being a person that uses drugs. So, for example, having a migration background, their gender identity or sexual orientation, having a disability or experiencing homelessness, or as some of you were saying, also age. So what we see is that these barriers are often really, really high. And especially standardized health services often require very formal referrals or paperwork that is very, very high threshold for a lot of people. For example, because of their insurance situation. So we have an ambulance going outside of here, so maybe you're hearing it. for example, because of their health insurance situation and experiencing administrative barriers, or as I was saying, also stigma or language barriers, not being able to communicate with healthcare providers, homelessness, or also geographical distance, just being far away from an area where services are available, or other reasons. But what we see is also that where community-led harm reduction is actually in place, then services are more accessible and do a great deal of work in building trust and reducing stigma and creating a welcoming space that makes people feel respected. And this all makes services way easier for people to access. So here is where also the importance of peer work comes in, because obviously people are more likely to trust and feel comfortable in services where they see peers with similar backgrounds. And this can also include involve, for example, including LGBT peers or women in your services, or peers with migration experience on top of the experience, the lived experience of using substances. So something else is that at present, the people with lived experience are usually more involved in services than people with current living experience. And that most peers in services are active as volunteers and less often as staff that is actually paid as part of the service. And most usually peers are involved in service delivery and operation, but less maybe in the initial design of services or governance. And this is valid also when it comes to policy. And something that I wanted to really stress today is that peer involvement has to go beyond only volunteering or kind of tokenistic roles. Peer involvement also means making peers actual decision makers and leaders within projects or policy processes, and working towards empowerment in that sense. Something also, sorry. Something also really important is that of valuing lived experience as expertise. This is something that is very often not recognized, but we strongly believe that the personal experience of people using substances is actually expertise and should be valued as such. And for instance, we can also see that communities already are supporting each other, and there's a lot to learn from how they're doing that. So this is a little bit what I wanted to stress today, and a little bit this webinar with this recommendation. And thanks again for having me.
Thank you, Ari. It is our pleasure, and it's great. You did it in very briefly, but you brought us this global evaluation, global European evaluation on community-based and led initiatives. Thank you so much for that. We only have 2 minutes to close. I don't think this gives us really time to put questions and answers. But Joanna, I would like to hear from you. I know that in the chat there has been some questions and answers being. Do you think we should let some time more for questions? The question is that our commitment is 1:30, and I believe that everyone should have must have some other commitments after. I would suggest that maybe we could go on writing, unless someone will tells me otherwise, because we will share the resources, and well, I think maybe we could go on if some questions or follow-up questions can be made after. What do you think, Joanna? I would like to hear from you.
I do think that people in chat that had like some dialogues, I've already the context or I changed the context, and I guess for maintaining, keeping the time right, we can also reach you in case we need any specific contact, for instance, from Roman to explain a bit more on community building. And I see also some questions for Thomas. So yeah, I will leave here your email and people can just write you back, I believe.
Okay, so yeah, I think there could be, it was very interesting and stimulating to hear you. But well, we gave all the time we had, and so we have shortened this section of the webinar, but let's do it like this. If you have questions, please let me know, and I will follow up with the speaker, okay?
Okay.
So thank you so much for coming, to all speakers, to all partners and participants for joining today. On behalf of INPUD, thank you again and see you at the next session. We will follow up with the slides and resources. Bye-bye.
Thank
Keep in
you,
touch.
Thank you very
merci,
much.
ciao,
Bye.
adios,
Thank you
auf
all.
Bye bye,
Wiedersehen,
everybody.
tschüss, bye.
Thank you.